Good morning, everyone. Thank you for joining me today. We're going to talk about male urinary incontinence. My name is Gladys Singh, and a little bit about myself. I did a reconstructive fellowship, and that's why I chose this topic. I did both reconstruction in female and male reconstruction, and thank you for joining me again. So ask questions on Twitter using hashtag UCLAMDchat. All right, so learning objectives today is what is male urinary incontinence? Why did I select out the male gender? It's just the anatomy is different, so we're going to talk about the anatomy there, and therefore there's a lot of overlap between male and female, but the anatomy is different in the male, and that's why it's kind of too broad to talk about both. And I wanted to select out male today, so we'll talk about the relevant anatomy in the male urinary system and the whole urinary tract, some background information about incontinence in America today, and some main forms of incontinence that affect males, and also causes and general evaluation in the office, or what we need to do, and then treatments going forward. Okay. All right. So the definition of urinary incontinence is the involuntary loss of urine, which is objectively demonstrable, and a social or hygienic problem. That's from the International Continence Society. So relevant anatomy, just broadly, these are your kidneys, and they produce urine that travels down these ureters that sits in the bladder. The bladder has two functions, to store and empty urine, and this is the male urethra, or the urinary channel that it comes down through, and this is where you void out, which is also where the penis is. And just looking at the neural control of avoiding, there's a lot of the brain and the bladder have to signal each other to say when they're ready to void. So when the bladder gets full, the brain sends a signal down and it says, okay, you're ready to void. So there's a lot of nerve fibers that go down, and also this is the muscular external sphincter, the striated sphincter, which is the muscle that you squeeze down if you're going to stop midstream. And if you had to pick up and leave, or a fire alarm went off and you had to stop midstream and run out, this is the muscle that you'd squeeze down to stop your stream, and that's important. And so this is the bladder with all the nerve fibers, and you can see that there's a lot of signaling between the different areas of the spinal cord and the brain down to the bladder, and that's what just wanted to show you in this picture. And so looking at the bladder a little bit closer, the bladder is a hollow, distendable muscular organ. So it's like a muscle bag that stores urine in here. And so the capacity is about 500 on average. Desire to void, or the time that you feel that you need to go to the bathroom, is about 200. And your normal voided volume is about 300 milliliters on average. Everybody has a little bit different. And the bladder sits behind the pubic bone. In the female, it's against the front side of the vagina, and the male it's above the prostate. So the prostate would sit here in the male, and this is the trigone, a sensitive area of the bladder, and this is again the striated sphincter, or the muscles that you squeeze down to hold or to control your your urine. So when we talk about incontinence or leaking urine, as we're talking about, it could be a function of the bladder itself, the bladder squeezing down and squeezing so hard that it bypasses the muscles, and that's what you call urge, and we'll talk about in a little bit. Or it could be, it's not shown in this picture, especially in the male, that it could be the muscles being weakened from after procedures or surgeries, or it could be blockage in this urinary channel, either from the prostate being enlarged or from strictures that can be along the male urinary channel. So let me show you a little bit better on this picture, because this is more dedicated to the male anatomy. Again, the bladder sits up here. As I was saying, the prostate sits here, and the prostate can get enlarged as men get older. And then this is the area of the urethra, which is not drawn in this picture, but this is where the muscle, the sphincter muscle, sits right in this area, and this is what clamps down, and this is the urinary channel, the penile urethra and the opening to the urethra coming out, and that's where all the urine gets expelled through this channel right here. And then just putting it all together to look at, giving another perspective in the pelvis. The bladder sits here, the prostate sits here. This is where the muscle sits, and this is the rectum, and this is the urinary channel coming out. Okay, perfect. So what are the key statistics to urinary incontinence in men? About a quarter to a third of men and women in the United States suffer from urinary incontinence, but that estimated 25 million Americans have incontinence, and there is a majority of females over males, about 75% women and 25% male, which means about greater than 5 million men that have urinary incontinence issues. Risk factors for urinary incontinence in everyone is advanced age. You can also have neurologic illnesses with multiple sclerosis, which probably affects females more than males, but also diabetes and stroke, obesity as well, and then Parkinson's as well. And also urinary tract infections can irritate the bladder such that you'd have urinary incontinence during the episode of an infection. And then in male, specifically prostate enlargement, as we mentioned, and also previous pelvic surgeries. If you'd had, bowel resection for bowel cancer, surgery down in the pelvis because the nerves to the bladder and the bowels are in the same space, and also if you'd had a prostatectomy or even resection of the prostate through the urethra. What are the consequences of urinary incontinence? It's generally a decreased quality of life. It's a social withdrawal. It can lead to depression and also embarrassment with leaking urine and smelling like urine. And sometimes family members are unable to take care of family members because are incontinent family members, and that's why they put them into institutions for them to have closer care. It also impacts, clinical outcomes if you have ulcers in the area, if you're leaking area into wounds, and sometimes if you're leaking on the floor, increased risk for falls, if you're already using a walker and things of that sort, and also sleep deprivation because you're leaking urine all over your bed, you're aware of that. And so total cost to urinary incontinence as a broad figure is about $19 billion. So just to talk about some of the three main forms of male urinary incontinence, there is stress urinary incontinence, which we're going to go through, and urge urinary incontinence, and overflow urinary incontinence. And most of the incontinence in men is really due to prostatic problems, as we'll talk about in a bit. So urge incontinence, usually people come and say, I have to go to the bathroom all the time. Sometimes the urge to go comes so suddenly that I can't make it to the toilet in time. And this is a picture of the bladder spasming, squeezing out, and the muscles can't hold the urine in, because as remember I told you the muscles kind of clamp things down, and because of bladder spasming, you leak urine, and the leak is described as sudden and cannot be stopped. And things that can cause urinary incontinence, is infections, or you can have tumors, things of that sort, or just general nerve problems that cause the bladder to be overactive, or something like overactive bladder. Now, stress incontinence, people usually come in and say, I lose control of my urine when I cough, sneeze, or stand up. Usually when they change their position, or if it's really bad when they're walking around, just from the extra pressure down there, they leak urine. And it's involuntary leakage associated with increased abdominal pressure. So the muscles are weak here, and the bladder gets pressure from the outside rather than from the inside on the last picture. And just because of that pressure from the outside and the weakened muscles, the person leaks urine. That's called stress urinary incontinence. That also happens in females as well, but for different reasons than men. And then overflow incontinence, which typically happens more in men than females, is that I leak urine unexpectedly, and I don't feel like my bladder empties after I go to the toilet. So the bladder's all full, and there's either a blockage, either the prostate, or you can have strictures, or things of that sort, or scar tissue in the urinary channel. And because the bladder's so full, it just slowly leaks urine out because it's past its capacity to store any more urine. Because remember, the bladder is a muscular bag. And so here's a picture of what a bladder that's been living through so much pressure and so much time. It's what we call neurogenic bladder. So this is what happens when people have neurogenic bladders. Their bladder becomes elongated like a Christmas tree look with all these little outpocketings. And that's what we call neurogenic bladder. People maybe with multiple sclerosis or Parkinson's can have these kind of conditions. And then this is a picture of an over-distended bladder from urinary obstruction probably in the urinary channel or either prostatic obstruction, and that's what it looks like on an imaging study. So causes, sorry, that's spelled wrong. Causes of urinary incontinence in men. So some of it is nerve damage, as I mentioned. So conditions such as diabetes, just like you get that glove, like glove foot stocking, inability to feel your nerves, you get the same thing on your feet and hands. You get the same thing in your bladder where you become insensate to your bladder. In advanced diabetes, that can happen. You can also have people with stroke where they have disease up here, or Parkinson and multiple sclerosis in the upper tract of the central nervous system, and they become their inability to signal to their bladder that they need to empty out, and so they can get full. And so a lot of times they can have incontinence, urgent incontinence from that. A lot of times Parkinson's patients come in with a lot of instability in their bladder, overactive bladder, and you get that a lot of urgent incontinence as we spoke about. And then overactive bladder as well, where the bladder spasms unexpectedly. And then also when you get patients with spinal cord injury, if it's high up here, you get a lot of detrusor overactivity, which is, or overactive bladder, where the bladder spasms a lot and you can leak urine. Or if you're have a spinal cord injury down the lower part of the spinal cord, you can have a areflexic bladder that doesn't signal and just gets full and full. You can get overflow incontinence with that, and you have to empty out the bladder yourself. Another cause of incontinence in men is prostate problems, or a main cause of urinary incontinence in men is prostate problems. So a lot of it is benign prostatic hyperplasia or an enlarged prostate gland, as you can see here, which blocks the urinary channel so that there's a lot of obstruction to flow. And you can get a lot of urge symptoms as well as overflow incontinence because the bladder gets full from the obstruction. And then you can also get incontinence from after prostate cancer treatments, either from radiation or prostatectomy. You have a prostate here with cancer, and after the prostate is removed, sometimes it may take time to form or regain strength. Sometimes the muscles gets weakened, and then you can have transient stress incontinence, which is typically what happens in men. The stress incontinence typically happens in men after prostate cancer treatment, or if it's long-term, then we can talk about treatment options for that. So basic evaluation of a male urinary incontinence in the office, basically, I generally do a general health history. Want to know what their International Prostate Symptom Score, which is a validated questionnaire, which asks them about their urinating symptoms, if they're intermittent, they're frequent, if they feel like they empty their bladder, how their stream is, if they're straining, if they wake up, how many times at nighttime do they wake up to go to the bathroom, and how urgent they are. And also, it is worthwhile to, since I only see people in the office for 30 to 40 minutes or at a time, and do an assessment of that time, it's good to have them do a voiding diary where they collect at least 24 hours or 3 days, 24-hour periods of their how much fluid they intake and what their urinary symptoms are. So sometimes I would send patients home with some homework to do to fill up a voiding diary so I can better understand their symptoms. And then also to know what their, as we were talking about, what their general health history, if they have diabetes, if they have other medical conditions that would affect their urinary symptoms. Sometimes if you have patients with depression that are on a lot of antidepressant medications, that can also affect their urinary symptoms as well. So we have to look at patients as a whole. And then on physical exam, it's good to examine the genital urinary area, look at the penis, see if there's any strictures or if there's any scar tissue, especially at the tip of the penis. If it's difficulty there, sometimes you can have inflammatory skin conditions that can start at the tip of the penis, block the urinary channel going backwards, so that can cause a lot of backup to the bladder, or overflow incontinence or urgency as well, because the bladder's not completely emptying well. And then also, if there's any neurologic signs, if they come in on a walker, or they come in with a cane, or there's one side that's weaker than the other, And also there's reflexes that you can test when you're doing a genital urinary exam, such as the bulbocavernosus reflex. And you can see what also the tone of the rectum is when you do a rectal exam, to one, feel the prostate, the size of the prostate if it's still there, and then if there's any tone to the rectum, to get a sense of their neurologic and muscular tone. The other thing I also like to ask, which I don't have on the slide, is about their bowel movements, because the bladders and the bowel share the same space in the pelvic cavity. A lot of urge can be because of patients being constipated, with the bowels kind of crowding out the bladder, and the bladder not having enough space to be able to expand and fill up. And that's one thing I assess also when I do a rectal exam, if there's a constipation. Some tests that we do also is to take a urine sample. If they come in with frequency or urgency, first thing you want to do, make sure there's no infection, because that's easy to solve. So we get a urine sample, do a quick urine dipstick, and see if there's any evidence of infection. Men don't typically get infection in the urinary tract, so if they do, then you got to think of other things as well. You also want to look to see if there's blood in the urine. If there's blood in the urine, then you may want to do a different workup, because you're concerned about if there's stones, if there's infection, as we just talked about, or if there's tumor in the urinary tract that's causing irritation. Also wanted to see what their post-void is, meaning that when they go to the bathroom, how much comes out, and then how much, when you bladder scan them, is left in the bladder. And then you can know if they're emptying their bladder well. So it's a relative volume of what's remaining in their bladder on a ultrasound, a quick, easy ultrasound, and that can tell you if they're emptying out their bladder well or not. If they come in with distended bladders and on exam their bladder's up to their belly, you also want to consider doing renal function studies, because a lot of times they could back up to their kidneys and cause kidney failure. And we want to catch that sooner rather than later, put a catheter in to drain the person's urine and decompress the whole system. And then also imaging studies, as well as such as ultrasounds. We could start with ultrasound or CT scans to see if there's any swelling in the kidney. And then, the laboratory study was the renal function studies to see if there's any elevation in their kidney or decrease in their kidney function. And then cystoscopy is where we take a scope and take a look in the bladder. This way you could also take a look at the urinary channel, look to see if there is a lot of blockage from the prostatic tissue, if there's scar tissue along the urethra, and also gives you a general assessment of what the bladder looks like when you put the scope in there. And if you go in there in the bladder, you see all these out pockets, these diverticulum, you know that person had a long history of obstructive voiding, so that maybe their bladder is not functioning so well. It looks like that neurogenic bladder that I showed you on that X-ray. And also it gives you an idea of once you fill them up with a scope and you take it out, you can have them void and also see what their stream looks like as well, after you fill up their bladder from the cystoscopy or taking a look in their bladder. And then the other gold standard test to do is a urodynamic study. And this study is a functional study where they test the bladder's capacity to fill and also to empty, as I told you earlier, the functions of the bladder. So this is a functional study, and it'll tell you exactly what the capacity of the bladder is. Maybe the person has urge urinary incontinence because the patient's bladder is really not able to expand. It is a small contracted bladder, which you can get sometimes after radiation treatment for prostate cancer, which the bladder becomes contracted, it's not able to expand, so the person is feeling like they have to go to the bathroom all the time. So this study can help you assess the capacity of the bladder, the stretchability or the compliance of the bladder, and then also helps you assess the voiding phase of the when the person urinates. So that's a great test to do. It is kind of time consuming though. But important signs and symptoms to take note of and especially see a specialist for is if there's recurrent urinary tract infections, especially in the males, as I mentioned, that men don't typically get urinary tract infections. So if you're getting a lot of urinary tract infections, that's important to see your doctor and get checked up. Also, if you see blood in your urine, if you void and you see a lot of red coming out, or sometimes if your primary care doctor will test your urine for analysis and see some blood cells in there, and there's a certain threshold of blood cells that specify its abnormality, then that's also some a reason to see a specialist. In men, sometimes, as I was mentioning earlier, it could be infection, it could be tumor. Sometimes it's just the prostate gland being big, and as the prostate gland gets bigger, there's a lot more recruitment of blood vessels to it. And sometimes after you urinate, at the end of the stream, you can have a little blood come out. But it's good to get that checked up with a specialist to make sure that is indeed the case. And then also, if you feel like you're not emptying out your bladder and you feel your bladder is always full and you can actually feel your bladder, sometimes I examine men and their bladder is all the way up to their belly button, then you want to definitely see someone to get some treatment immediately. And probably the most acute way or immediate way to drain that is to put a catheter in, or be taught how to put a catheter in if you're unable to void, if the bladder is unable to squeeze things out, either because there's obstruction or the bladder has nerve damage. So treatment options, in general, there's behavioral treatment options, there's medicines to give, you could do less invasive, like Botox injections in the bladder, especially for urgent continence, and then also electrical stimulation for urgency as well, and then also surgery. And this is very broad that I've had listed up here, and I'm going to kind of specify each kind of treatment option to some of the cases that or some of the specific situations that we spoke about. And there's no one treatment for everybody. So it kind of depends. When you're talking about treatment for any of this stuff, you really have to discuss with the patient themselves what are their goals of treatment, how invasive do they want to go, what are their plans or environmental situations, their capacity to maintain things. And so it's a discussion that you have with the patient in terms of what the treatment is. But to start off with behavioral, that is easy, and that can actually be recommended to everybody that comes in with some kind of urinary incontinence issues. But because it is quite good, and it's easy to do. And it works in the sense that there's 40 to 80% reduction in incontinence episodes among studies. But basically, it's limiting fluid intake. If there's a lot of urination at nighttime, then stop drinking 3 hours before bedtime. And this is where the voiding diarrhea, as I mentioned, comes in, because then we can kind of analyze what you drink, how much you drink, and then when you have your episodes of incontinence. But so this is how that kind of plays into its role. Also, you could do time voiding, meaning that sometimes people feel like they're urgent. Really, at the end, they let their bladder get so full, and they feel like they're urgent, they're leaking right before they get to the bathroom. But it's really because they've waited 6 or 7 hours until their bladder has gotten so full, and they put all their attention on voiding or going to the urinating, and then they, just a couple of seconds before getting to the toilet, that's when they leak urine. So if you avoid waiting for your bladder to get so full, you can avoid leakage episodes as well. And then the other thing is the pelvic floor exercises, or the Kegel exercises. Remember that muscle I showed you earlier, the striated muscle? That's the muscle that you would squeeze, and you can practice that to strengthen the pelvic floor muscles, especially sometimes if you've had surgery to the pelvic, to the prostate or the urinary channels. You can strengthen that muscle by squeezing those muscles and doing 10 sets and holding each for 1 second each time you squeeze down on it, and you could do like 3 sets a day with a focused effort. Just like if you're going to lift weights in the gym, you're going to work on your biceps, you want to focus on your biceps and hold the weight. So same thing, and it takes time to strengthen, but that's exactly what these pelvic floor exercises are. But the key is sometimes to make sure that you're using the right muscles. A lot of times people strengthen or tighten up their buttocks or their thighs, and that's not the right muscle. So the way you know it's the right muscle is that if you're urinating midstream, and like I said, if a fire alarm goes off and you have to pack up and go, those are the muscles you clamp down in order to stop your stream and put your pants back on and run out. Okay, that's how you know you're using the right muscles. All right, so in terms of specific causes of urinary incontinence due to a big gland, a big prostate gland, or BPH, benign prostatic hyperplasia, or enlarged prostate, there are medications that we typically start people off on, which is these alpha adrenergic antagonists. They are alpha blocker medications. Probably you've heard of them: tamsulosin or Flomax, doxazosin, terazosin. And what these medications do is they help relax or smooth muscles in the bladder neck, so that it can help with the flow, increasing the flow of urination. And studies have been done which shows that in 53 weeks of using these medications, there's about 31 to 36% improvement in the maximal flow rate with using this medication versus 21% with people not taking any of the medication. And we kind of assess this because when you come to the clinic, the office, we have a Uroflow machine where you can urinate into a funnel that measures your flow rate. So, and that's also based on the patient's improvement in their symptoms, or they feel like they have a better, easier time to urinate. And then these other medication is the type 2,5 alpha reductase inhibitors. These are the finasteride or the Proscar or the Avodart. And what these medications do, it takes time for these medications to work, but they reduce the synthesis of a more potent form of testosterone within the in the gland, and results in the atrophy or the shrinkage of the prostate gland. And so it's about 20 to 30% reduction in the prostate volume. And with the combination of these two medications, this one and the one we just mentioned, a lot of men are maintained well with having an enlarged gland. I mean, there are some side effects associated with this medication, but I've seen that in most men that I've prescribed this to. We discuss it, and I've not had too much complaints. But there are side effects of ejaculatory dysfunction, meaning that there's retrograde ejaculation because the bladder neck is open, so it's the ejaculate will go in the path of least resistance. Sometimes there's loss of libido and erectile dysfunction, and then enlarged chest. But I haven't seen that happen. I haven't seen a lot of men complain about these side effects. But with these two medications, a lot of men are maintained well with their urination. And then if you're not taking these medications and it doesn't work, or you can't tolerate any of these medications, then there's surgical procedures where you resect the prostate gland, and we use a camera these days. We don't use our eyes, but we put a scope in there, and at the end of this tool is a loop where we can resect. We can also do it by laser, which it vaporizes the gland that's big, that's blocking the urinary channel. Okay, and then sometimes after radiation treatment or surgery for prostate cancer, you can get scar tissue that forms there that blocks the urine, and you get the overflow incontinence that we spoke about. You can also use one of these instruments that we have here to open up the scar tissue. Now, for urge incontinence, a lot of it is behavioral and lifestyle first, and then we talk about medications that we can give, such as the anticholinergics, medications such as oxybutynin, Detrol, and we like to give extended release tablets. Or there's a new one out called Mibetrik, which is a beta agonist that helps with decreasing the spasms within the bladder, and so it decreases the volume of contractions and kind of calms down the bladder, so you don't have as much urge, which is, remember, where you get the sudden loss of control of urine because your bladder spasms and pushes the urine out. And also can help with increasing the bladder capacity as well, and decreasing the amplitude of the contractions. And then if these don't work, third line is really you can do a less invasive procedure where you inject Botox to kind of calm down the muscles of the bladder, and that's more bladder selective because you're actually getting, instead of taking a systemic pill, you're going inside and treating the bladder with these injections. Okay, and that's the Botox injections. And then there's other types of treatment as well. That if the medications, the lifestyle modifications don't work, then you do, their functional electrical incontinence, this is a posterior tibial nerve stimulation, which is these are the S2, S3 nerves and nerves to the bladder. So you can implant these. This one is a surgical procedure to implant a device to help stimulate the nerves that go the S3 nerves to the root to the bladder. And you could try with a percutaneous trial first to see if it works, and then you have to go in the operating room. You implant these electrodes. So you get a 2-week trial, and then if it works, and then you implant it in, and then you carry the device around, and then it gets programmed. So it's pretty automatic. This is just the trial period, and then this is another one which is not as long lasting, but it is less invasive in the sense that you have a device that you put on the outside, and you just access the posterior tibial nerve, which goes to the same nerve root here, the S3 nerve root, and then you have 12 weekly percutaneous stimulations, 30 minutes each, and then it has to be maintained. But the studies show that it doesn't last as long. There isn't as well as the sacral nerve modulation. But these are other ways to treat with the urge or the overactive bladder component associated with incontinence. And then to talk about male stress urinary incontinence, as we mentioned, that it was due to prostate problems and prostate treatment for likely cancer, not necessary for stress urinary incontinence, meaning that sometimes the muscle is weak, and if you cough, laugh, and sneeze, you leak urine because the muscles are weak, because they've either been irradiated or you had surgery down there. And after about a year's time, if things don't recover and there's still a lot of stress incontinence, then we could talk about procedures or surgeries or even devices, then surgeries to help with treating that problem. There are certainly external clamps you can put on the penis itself, or capture devices that are in the underwear that go into a bag that help with catching urine, to help with leaking urine. But if most men don't like that, if you don't like wearing a clamp, then the surgical option to treat that is really a sling, a male sling, which helps support displaces the urethra and supports where the muscles used to be to help with being continent. Or you can do an artificial urinary sphincter, and which is a device that you surgically place, and it almost serves like the function of a sphincter, which there's a reservoir of fluid. It's a pressurized system where you have to pump this to release the pressure on the urinary channel, which is the urethra, so that it opens up and you can void. Otherwise, it fills up and closes up so that you're not leaking every time you stand up, cough, laugh, and sneeze. And same thing with this. This puts the pressure on so that there isn't any leakage. Now, how you choose between these two is it depends on how much leakage there is in your patient. If they're wearing 2 to 3 pads a day, less than 250 milliliters of leakage, not so wet, then their leakage isn't that bad, then you can use a sling. But if their leakage is constant dribbling, leaking out, then I would say a artificial urinary sphincter is the better option for them. But in talking about these devices, you have to understand that there is also they're both surgical procedures, and that this does require some manual dexterity, because you have to be able to pump this, use this pump, which will be implanted in the scrotum, and you have to use that every time to be able to open up the channel to be able to void. So there's, a lot of discussion. That's why I say it's patient selection, and also what your expectations are very important when you talk about these kind of procedures. But, the quality of life for using these, the sphincter is quite high. I mean, there's this study was done by a group up in Canada, and their sample size wasn't big, but they talked to 39 men, and they asked them what their perception of their urinary condition was after the artificial sphincter, compared to leaking a lot. They felt that they were much better. Most of the men felt they were much better. About 20 of the 39 men felt they're much better. And then they asked them, if knowing what you know now, when you have already the sphincter placed, would you do this again? And the majority of the men said that they would have the sphincter placed. And then this just shows how much leakage they have after they had the artificial urinary sphincter placed, which is afterwards, and that there's a much decreased amount of leakage after the artificial urinary sphincter is placed. So in summary, a lot of male urinary incontinence a lot of it's related to prostate problems and or nerve damage. Most majority probably prostate problems either from blockage or obstruction and after prostate cancer treatment. First line is talk about behavioral modification. As we mentioned, we like to start conservative and then work with a patient to see, you know, what their goals and expectations are. And then if there's medications for urgent incontinence, we try that, and then move to more invasive treatments as long as we understand what their expectations are. And then I think you want to see a specialist to do these workup management to they have the volume of doing these procedures and also seeing these type of patients. And then, as I've been saying, management depends on the patient's goals and your expectations of therapy, as well as how invasive or the degree of treatment that you want to go through. Thank you. Well, thank you. Okay, how can I best prepare for urinary incontinence surgery? It depends on the type of surgery that you're going to have done, but you know, for my there's many surgeries as we mentioned, so it's hard to say exactly what type of surgery you're gonna have. But typically, you know, we want to make sure that you don't have an infection or any other obvious reasons for your incontinence. As I mentioned, if there's stones in there or that your bladder's irritated for, if you have tumor, things of that sort, or infections. Those are things I would kind of rule out, but it's hard to say exactly what kind of prepare for what type of urinary incontinence surgeries there are, because there's multiple. And then, is there specific web resources you can recommend to read about or watch videos showcasing physical exercises for urinary incontinence? I think American Urologic Association has good resources for patients. I'm not aware of any particular videos or webs or anything to watch per se, but you can try the American Urologic Association, which is from urology, which is what we kind of turn to our guidelines and things of that sort. So you can look there and see if there's anything that they have specifically for patient education. Otherwise, I'm not aware of any videos. But mainly for that exercise I was talking about, the pelvic floor exercise or the Kegel exercise, you can know that you're using the right muscles. Is that when you're urinating midway and you stop it, and you're able to start and stop that stream, you're clamping down on the right muscles. Okay, and then my autistic son was often given Ativan and began to have severe loss of bladder control whenever Ativan was used. Is this common? Yeah, that can be common because Ativan is kind of relaxes your muscles and things of that sort. So it's you know, and especially if this happens when he's taking that medication, it's not uncommon that with that relaxation that, you know, they lose their bladder control. So I would, you know, if I know that he probably needs to take it for a particular reason, but if you can kind of cut back on that kind of medication, it would help with his losing control of his urine. Thank you.